Hello, my name is Crystal Henderson and I'm applying for the full-time position as the clinical coordinator and instructor. Today I'm going to do a teaching demo for you over chest radiography. We're going to first go over the anatomy of the chest and then go into the lab and work on positioning, and then we'll come back here to finish up about image evaluation. So first, let's go over the anatomy. We're just going to do the basic anatomy of the chest today. We're going to go over the trachea, the lungs, and then heart and diaphragm just a little bit. So let's first go over the trachea. The trachea is going to be anterior to the esophagus. That's going to be our airway that brings the air down into our lungs. It's made out of cartilaginous rings, and it'll come down to about the level of T4, and then it bifurcates or divides into two different bronchi, the right and left. The right bronchi will be something that we need to pay attention to because that's where foreign bodies can be lodged, because the right bronchi is shorter and wider than the left. So the bronchi is going to bring the air into the lungs. So we have the right lung and the left lung, and we'll have the heart in the middle, and then the diaphragm, which is what separates the thoracic cavity from the abdominal cavity. So we're going to go to the next slide and we're going to look at the lungs a little bit. So we have our left and our right lungs. The left lung is divided into two lobes, where the right is divided into three lobes. The right is going to be about an inch shorter than the left because we have to save room for the liver that's right here. The left is also going to be more narrow because it makes way for the heart. The most important thing that we probably need to remember when we're imaging the lungs in the chest radiography is our different parts of the lungs. We have our apices, which are the top, and then the costophrenic angles that are at the base or at the bottom. We'll go over it in an image evaluation, but it's really important that we know where both of these are so that we can see to make sure we have them on our chest radiographs. So if we'll go to the next image. Okay, this is just some honorable mention anatomy, some things that we need to make sure that we know where they are so we can evaluate our chest radiographs later on. So some honorable mention first is our clavicles, here and here, mainly the sternal end, or the end that's closer to the sternum. You can see here where the sternum and the clavicles meet, this little junction here, that's our sternoclavicular joint, or honorable mention number 2 on our list. Again, in image evaluation, we'll see that these are equal distance apart from the vertebral column to make sure that we're not rotated one way or another. Another honorable mention is the scapula. You can see those here and here on both sides. On a PA chest radiograph, we want to make sure that we roll the shoulders forward so that the scapulas are out of the lung field and not superimposing our lungs. Also, honorable mention is the ribs, anterior ribs and posterior ribs. We need to make sure that we can count those ribs because, again, that'll come in handy later on for our image evaluation. We have 12 ribs, but we need to be able to see 10 posterior ribs for an adequate chest radiograph. And next slide, please. Okay, so next we're going to go to the lab. We're going to walk through a basic chest x-ray exam, which is a PA chest and a lateral chest, and then we'll come back in here to go over our image evaluation just a little bit. Thanks. Okay, so we're in the lab now. We're getting ready to set up for our PA and lateral chest, which are the two images that we need for a chest x-ray. So we're going to set our room up first before we go get our patient so that everything's ready so that when we get our patient, we're ready to go and they don't have to wait on us. So first thing we're going to do is make sure that we're at a 72-inch SID, which is source to image distance. Our source is our x-ray tube, and then to image is our image receptor that's here in the chest bucky, wall bucky. So we're at 72 inches to the wall, or to the bucky rather. We have our 14x17 image receptor in our bucky, and it is in crosswise. We have our collimated field. We have it down to 14x17. I've also put my left marker on the board because when the patient stands up here in the PA position, which means posterior to anterior, this will be the left side of their body. So I've got my distance correct. I've got my image receptor in, the right size, the right orientation, so we're already there. I've already set up on the control panel my technique that I'm going to use for the chest x-ray. on an average patient, we're going to go at this facility 117 kVp with about 4 mass. So that's all set up and ready to go. So we're good there. So as we bring our patient in, we're going to make sure that we do a 2-part verification on ID. So we'll do name and birthday. We also want to make sure that we get a detailed history of what's going on, the signs and symptoms of why we're doing this chest x-ray, and any surgeries that they may have had that are relative to the area. If it's a woman within childbearing years, at most facilities, that's ages 12 to 50. We will ask the last menstrual cycle. And we can always shield for a chest x-ray, so we'll make sure that we do that as well. So we've got our patient. She's in here. Normally we would have the patient undressed completely from the top, but because this is a demonstration, we're just going to let her leave her clothes on. But you would have them remove their shirt. If it's a woman, you would have them remove their undergarments, their bra, any canvas soles, etc., because we don't want that metal or plastic to show up in our image. Also nowadays, we have to be wary and pay attention to piercings in the chest that will show up. Also any necklaces or any earrings that are dangling low. We need to make sure all of that is off. So we've already wrapped the shield around her. We're going to make sure that she's good and protected. And when these types of shields, you want to make sure that the shield part is at the back, because as she stands in the PA position again, those x-rays are going to be coming from this direction. So we've got our patient over here. She's in the PA position. We want to make sure that our image receptor is about 1.5 to 2 inches above the level of her shoulder. So there's her shoulder, so our image receptor is about 1.5 to 2 inches above. We also want to make sure that our central ray is going to enter at about the level of T7. So we are about the level of T7. I'm going to have her scoot all the way up. The central ray is also going to enter the midline of the patient's body. So I'm going to take my hand, I'm going to feel her spine, and I'm going to make sure that we're lined up with her spine. So also what we're going to do now, we're going to have the patient to roll their shoulders forward, depress and roll. When we do that, that gets the scapula out of the lung field like we talked about previously. So now her scapula are out of the lung field so that we're not superimposed over the lung. Breathing instructions are very important with the chest x-ray, because that's going to give us the different levels of contrast that we need. So what I'm going to have you do is take 2 big breaths in, and on the second big breath, hold it. You always want to tell your patient what to expect so that they're sure of what's going to happen. So you would go back to your control panel. You would tell the patient, take a big breath in, blow it all the way out. Watch your patient so that you can make sure that they're doing what you're telling them to do. Take another great big deep breath in and hold it, and then you would shoot your exposure. Make sure you tell your patient to breathe, and you can breathe and relax. So that's what we have for a PA chest x-ray. The reason why we want her to take that big breath in is because that depresses the diaphragm, so that doesn't obscure the base of the lungs. So the second part of our chest x-ray is a lateral radiograph. So for the lateral, we're going to turn her to face this wall. Her left side will be against the image receptor, or the bucky rather. The reason why we do the left side is so that the heart is closest to the image receptor, and that'll reduce the magnification of the heart. So her left side is against the board. We're going to scoot the shield to the side, because now our x-rays are coming from the side. We're going to lower the board just a little bit. And now we're going to move our marker to the front. We move it down here so that it doesn't get burned out if it's up where it was before. And also, this will be in tissue that we're not necessarily looking at, because we know her lungs are going to curve around this way and they're not going to be at the front. Okay? I'm also going to have you raise your arms so that the soft tissue of the arms and the bones of the humerus do not obscure the lung field. Excuse me. She's also going to step right up against that board. I'm going to put my hand across her back to make sure that her ribs are superimposed on one another and that she's not rotated in either way. We're going to turn the light on. And we can see that this isn't exactly lined up to the midline of her body. So I'm going to have her scoot back just a little bit. Very good. So we're midline to the body. She's good and straight. One thing that we need to make sure that we do is change the orientation of our cassette. So now we're going to go from crosswise to lengthwise. We're still at 14 by 17. And because I've dropped down our wall bucky, I also need to drop down our central ray so that we still have our two-part alignment. I'm going to change the collimation and we are good to go. So it'll be the same breathing instructions as before. I'm going to have you take a big breath in and blow it all the way out. And another big breath in and hold it. You can go ahead and breathe. And then we would shoot our exposure while she had that second big breath in. One thing that we would have done was to change the technique on our control panel. When we're going from a PA to a lateral chest, we do need to bump up our technique a little bit in mass because the thickness of our body is changing. She's a lot thicker this way than she is this way. So that's why we need to change our mass. So typically at the facility here, we use 117 kVp and about 7 mass for the lateral chest x-ray. You can relax your arms. Okay, so we're through with the lab portion. We're going to stop and head back into the classroom so that we can go over some image evaluation. All right, so now we're back. We're going to go over the image evaluation for a chest x-ray. We'll go over the PA chest first. These are things that we need to look at before we send the images to the radiologist so that we can send the most optimal images to them, okay? So for the PA chest, we need to make sure that we can visualize the entire lung field. That means from the apices at the top to the costophrenic angles at the bottom. If both of those aren't on that, then we need to shoot another image. We need to make sure that there's no rotation, that the sternal ends of the clavicles are equal distances apart. We need to make sure that the trachea, we talked about the trachea as our airway, that it's visible midline. You'll be able to tell that because on an x-ray, we know that air is black, and so that trachea will be able to see the black air going down. We need to make sure that it's midline of the body. We also need to visualize 10 posterior ribs. That lets us know that our diaphragm is down far enough that we can see those. And we need to make sure that we have adequate contrast or our shades of gray. We need to make sure that we can see the lung markings in our x-ray. So here's an example of where the trachea is not midline to the body. You can see that this patient's rotated because here are the vertebrae, and then this clavicle, sternoclavicular end, the sternal end is greater than the other side. So this patient's rotated, and you can tell they're also tilted one way. You can go to the next one. Okay, this is another example where it is not midline and that it's also rotated and they're not equal distances apart. What this image is showing you also is where we talked about how the trachea bifurcates. So it's showing you that bifurcation and how that's not midline to the body. So let's go over the image evaluation for our lateral chest x-ray. We need to make sure that there's superimposition of the ribs posterior to the vertebral column, that there's no arm or soft tissue overlying the lung field, that the lung axis of the lungs are in a vertical position. We want to make sure that our patient is nice and upright. They're not leaning forward, they're not leaning back. They're good and straight. We also need to make sure that there's no rotation of the sternum. If that patient's rotated one way or another, the sternum will be rotated. And we need to visualize again the apices and the costophrenic angles just like in the PA chest. It all needs to be on there for us to send it to the radiologist. Okay, here's an example of some rotation. You can see how the ribs are not superimposed on one another, and you can tell that that patient's rotated one way. And even though the arrows are pointing to the vertebrae in this picture, I like the picture to use as an example of this is soft tissue overlying the lungs, all through here. This is because we didn't get the patient's arms up, and that soft tissue is overlying the lung field. Okay, I've also included this QR code. If you scan this code, it's from the Society of Academic and Emergency Medicine. They have all kinds of different images that you can look at, not only to critique, but also pathologies. It's a great resource to use. And that's it. Thank you for your time today, and I hope you guys learned a lot and enjoyed yourselves.